Hello everyone and welcome to the HacettepePathology.com and Case of the Month series. In this month I'm going to show you a case, through-cut biopsy, core biopsy from a patient, 40 years old male patient with a primary huge mass in the adrenal region but metastatic to showing extensive metastasis to whole body, and they have taken a core biopsy from one of the metastases. It was consulted to our department, but the tissue was so small, and this is the only tumor was left. It seems to be an ugly tumor with lots of pleomorphism and hyperchromasia, and in the outside center it was synaptophysin positive. So this was synaptophysin. Here is the synaptophysin positivity, but I did several immunos, but the tissue has finished. So I reported this as a malignant tumor with neuroendocrine marker expression. I didn't call this like neuroendocrine differentiation, but because I'm not sure that this is because it was not supported by other neuroendocrine markers such as chromogranin or CD56. So I request a new biopsy, and this is also again from the metastasis. And I'm not going to go into details, but I'm just going to show the pattern. We have this nest-like, vaguely nested pattern of epithelioid cells. They are ugly looking. They have many mitotic figures over there, and we have also necrosis. Here is necrosis. So I ordered some stains like cytokeratin, and it was negative. And since I know this is an adrenal tumor, and we have this adrenal tumor in this patient, so this is EMA. EMA is focally positive. I'm going to show you. Yeah, this is better. So this is focally EMA positivity. Okay, focal. And I ordered synaptophysin. Synaptophysin was positive, as you see here. Yeah. And I consulted the case to my senior colleague, Dr. Sekmensier, and if it's good for adrenal metastasis, adrenocortical carcinoma metastasis. And I also ordered some markers used for adrenal, like calretinin or inhibin, melan A, but they were all negative. And he reminded me the basics. Okay, so I'm going to turn back and look at the case again. Of course, I was blinded by the clinics and synaptophysin positivity, but I just missed the morphology. Here, when we look at the case, what you see is the spaces, right, and the hobnail-like structures. And this spacing and hobnail, I mean, they are like just covering a space. Okay, so these these morphology should remind us vascular tumor. Okay, here, and this is again a good example with the malformed. I mean, the neoplastic cells try to produce vessels with blood in it, and then we order this CD34, and CD34 is negative. But I would like to stress something about the vascular tumors. I mean, CD34 is a good marker, but it's not that sensitive like CD31. I mean, morphologically, in such a case, like morphologically, we suspect angiosarcoma. I prefer to use CD31 and ERG. I mean, I would like to do both together. That will cover the weaknesses of each. And CD31 is, as you see here, clearly positive, strongly and diffusely. It may also be expressed by some other tumors like plasmacytomas or histiocytic neoplasms, but ERG will cover these weaknesses, and ERG is positive, diffusely and strongly nuclear positive, and ERG also has some weaknesses, like they are also positive in some other tumors like epithelioid sarcoma, for example, and they are also positive in prostate adenocarcinomas. But both positivity strongly supports the diagnosis of angiosarcoma metastasis. Synaptophysin has been shown to be aberrantly expressed in angiosarcomas, and recently it has been reported that some composite hemangioendotheliomas show neuroendocrine marker expression. But in this case, I am convinced with the diagnosis of metastatic angiosarcoma, given the fact that necrosis and the extent of the cytological change. Thank you very much, and see you next month.